Hi, this is the continuation of our discussion of shortness of breath in the elderly. Chronic obstructive pulmonary disease, COPD, is a chronic inflammatory lung disease that causes obstructive airflow from the lungs. Airflow out of the lungs becomes difficult. Symptoms include breathing difficulty, cough, mucus production, and wheezing. It's caused by long-term exposure to irritating substances, most often from tobacco, cigarette smoking. People with COPD are at increased risk of developing heart disease, lung cancer, and a variety of other conditions. Emphysema and chronic bronchitis are the two most common conditions that contribute to COPD. Chronic bronchitis is inflammation of the lining of the bronchial tubes, which carry air to and from the air sacs, called alveoli, of the lungs. It's characterized by daily cough and mucus production. Emphysema is a condition in which the alveoli at the end of the smallest air passages, called bronchioles, of the lungs are destroyed as a result of damaging exposure to cigarette smoke and other irritating gases and particulate matter. Factors that are the cause of COPD, again, are cigarette smoking, air pollution, infections of the airway, and hereditary factors. Also, something called alpha-1 antitrypsin deficiency. COPD is treatable. With proper management, most people with COPD can achieve good symptom control and quality of life, as well as reduce risks of other associated conditions. COPD usually presents at ages in the 50s or later. Again, there is usually excessive coughing. Again, this can be accompanied by sputum or mucus production. There can be shortness of breath and/or wheezing. The physical exam may find an increased rate of breathing, reduced ability to expand the chest, increased inflation of the lungs because of air outflow being restricted, decreased lung sounds when the physician listens to them with a stethoscope, signs of cyanosis. Cyanosis is an abnormal bluish discoloration of the skin and mucous membranes, and the patient may be breathless while sitting in the exam room. Investigative tests can be a chest x-ray. The physician will obviously order a chest x-ray, but the chest x-ray may be normal because characteristic changes of the disease process occur late in the disease process. The physician will definitely order pulmonary function testing. These are called PFTs. Pulmonary function tests are non-invasive tests that show how well the lungs are working. The tests measure lung volume, capacity, rates of flow, and gas exchange. A blood gas will be ordered. A blood gas test measures the amount of oxygen and carbon dioxide in the blood. It may also be used to determine the pH of the blood or how acidic it is. An EKG, an echocardiogram, will be ordered, and a full blood count will be ordered. Treatment. If the patient smokes, the patient will be instructed to stop smoking. The patient will be instructed to avoid contact with individuals who have colds or flu symptoms. The patient will be instructed to avoid secondary smoke, to avoid air pollutants as much as possible. The patient will be instructed on how to use a peak flow meter. Medications such as bronchodilators, which includes ipratropium bromide and corticosteroids, will be used. A bronchodilator is a substance that dilates the bronchi and bronchioles, decreasing resistance in the respiratory airway and increasing airflow to the lungs. Ipratropium bromide, sold under the trade name Atrovent, among others, is a medication which opens up the median and large airways in the lungs. It is used to treat the symptoms of chronic obstructive pulmonary disease It is used by inhaler or nebulizer. Systemic and local inflammation is central to the pathophysiology of COPD. Increased levels of inflammation have been linked to a more progressive course of COPD and have been shown to be present during an exacerbation or a worsening. Corticosteroids will help reduce the inflammation and progression of the disease process. But it must be remembered that long-term use of corticosteroids can have significant side effects. The performance of the treatment medications will be monitored with the use of a peak flow meter, and changes will be made as needed by the physician. Antibiotics will also be prescribed to address acute episodes of infection in order to limit further damage to the lungs. Referral should be made to a pulmonologist when the disease initially presents. The primary care physician and pulmonologist can coordinate long-term care for the patient from that point. We will continue our discussion in the next and last video on shortness of breath. Well, I hope this helps. Have a good day.